We are recording the session today, so please don't include any confidential patient health information, if at all possible. No names, no locations if you can. It's a rural state. We do offer CME, CEU certificates for these sessions. It's 1.0, and we do need you to at least chat to us using the chat screen, or in a moment we'll have some time for you to say your name over audio and just let us know where you're from. That's always nice to know. Computer video and audio, we'd love to have you on camera. I see we have at least one person on there. Thank you, Jillian. And nice to talk to you earlier. If you need to mute yourself, it's on the bottom left of your screen, and just click on that old school microphone icon and you can mute yourself, as well as the video if you need to do that. Our disclosure and accreditation statements are on screen right now. We do offer case consultations. Molina and Blue Cross Blue Shield do offer some reimbursement for those case consultations. We don't do that for our PEDx sessions, but for some of our others, it's a very underutilized service. So please get in touch with us if you have any need for that or any use for that. You can be reimbursed up to $150 for Molina and about $75 from Blue Cross. So keep that in mind. And at this point, let's go ahead and do roll call. If you are on audio, please unmute yourself and let us know you're there and where you're from. Otherwise, I will jot you down from the chat box.
Hi, it's Jillian Merritt, Tahatchee Clinic.
Hi, Jillian.
Richard Stam from Albuquerque.
Thanks, Richard.
Sherry Alderman from Portland, Oregon.
Hi, Sherry. Okay, and I think everyone else is going to go ahead and chat in. And so I'll go ahead and turn it over.
Great, thank you. Well, thank you all for joining us. I'm Melissa Mason. I'm the immediate past president of the Pediatric Society, and I really appreciate Envision enabling us to have these sessions. And it is my great pleasure to introduce to you Dr. Kim Foster, who came to UNM from St. Jude. She is a pediatric neurosurgeon, and we're really pleased to have her. So thank you.
Thanks, Melissa. Thanks, Kevin. So I am now the pediatric neurosurgeon at University of New Mexico and the Children's Hospital there. And I just wanted to talk to you guys about some common pediatric neurosurgical diseases that I encounter in my clinic and that you guys see primarily and send over to me. Thanks for having me. No disclosures. So my objectives today are to discuss evaluation of abnormal pediatric head shape, discuss pediatric hydrocephalus and management of shunts, to talk about considerations in children with spina bifida, and understand the evaluation of pediatric tethered cord. These are the questions that I had sent out previously in relation to this talk, and we will answer them by the end of the talk. The most common head shape abnormality that I see in clinic, or we see in our head shape clinics, we'll talk about that. Most children with spina bifida have shunts for the treatment of hydrocephalus. This, of course, is true, and it's an important thing to consider with these kids. How we as neurosurgeons follow children with shunts, when and how, and what's the best way to evaluate tethered cord, which is also a common thing that we see. So in my journal, the Journal of Neurosurgery Pediatrics, there was an interesting article that talked about prioritizing neurosurgical education for pediatricians, and it's a result of survey that was given to pediatric neurosurgeons in terms of what they felt was would be important for their pediatric colleagues to know and understand. And so over 200 neurosurgeons, practicing pediatric neurosurgeons, responded. The three disease entities they felt were in greatest need were craniosynostosis versus and in relation to plagiocephaly, occult spinal dysraphism, so the kids with a hairy tuft on their back or a dimple, and then what's underlying that, and of course hydrocephalus and shunts. Quote, it may not necessarily be congruent with the perceptions of practicing pediatricians themselves, but this was what, sort of my end of the world thought would be important to discuss in purely opinion. In general, pediatricians were asked, and up to a quarter of them said that they would have liked more neurology education in residency. This information is taken from a CME survey that was given to pediatricians. Neurosurgery not really included, but just in general, understanding the neuroaxis and the neurologic evaluation. I think, if you talk to a number of pediatricians, they feel like maybe they could have had more education in their training. And the Pediatrics Review and Education Program put out by your association, the AAP, since 1979, there have only been 10 articles that relate somehow to neurosurgical issues, mostly on trauma, spina bifida, and one on head shape. So let's get into our first topic, which is one of the most common head shape abnormality, which is fortunately really not pathologic, is that of positional plagiocephaly. So plagio comes from the Greek word meaning skew, and its incidence is up to 5% of all children, and it is actually increased due to the Back to Sleep campaign. And in general, prevention is thought to entail increased tummy time, alternating the end of the crib the baby sleeps on, alternating toys or distracting things or things the child likes to look at, putting mirrors in the crib in alternating positions, and limit the time that children are sitting around in car seats or their strollers. Of course, in the differential diagnosis for this, and why I think it's important, or you guys often send these kids to have us take a look, is could this be something more than plagiocephaly, such as lambdoidal synostosis? Frontally, could it be coronal synostosis? And then is there an issue of torticollis? Here is a picture showing the difference between plagiocephaly, which is on the left, and true synostosis, which is on the right. So the classic way we talk about it is this picture that's in the middle, that's just a drawn out picture, is that the parallelogram on the left in picture A there is plagiocephaly, and then the trapezoid is the synostosis. And so with plagiocephaly, it's really just a skewing of the shape of the head and compensatory. So on the side, so on this kid in picture A, the kid's right side, we're obviously looking from the top, has flattening, and it kind of pushes everything forward. So the ear, because it's being flattened in the back, is pushed forward. The frontal side boss is on that side, and then on the contralateral side, on the side the child is not usually positioned on, it's rounded and it's bossed, but it's really the normal shape. Synostosis is closure of a suture. So what it actually does is it does the opposite. Because the bone is actually closing there, it pulls everything back towards it. So the ear is actually pulled back towards the area of fusion. The frontal area is actually pulled back towards the affected side, and this is obviously pathologic, and we often do something surgical about it. The best way to evaluate this, and this is how I look at kids in clinic, is to stand how this pediatrician is standing here in this picture, mom or dad holding the baby and standing from behind and looking at the top of the head. Sometimes I even put my fingers in the ear and see. So you identify the side of flattening, and then is this either positional or is it synostosis? And then you look at where the child's ears are. If they're pushed forward, it's probably just flattening, which is what we're going to see 98% of the time, and if it's or more. And if it's pulled back, then we would worry about synostosis. And also to check the position of the infant's forehead to see if there's compensatory bossing because of the positioning. So how do we manage plagiocephaly? Actually, recommendations in our literature just came out. They were mostly level 2 and level 3 because there's not a lot of good evidence. But basically, under 5 to 6 months of age, if a kid comes to clinic still very young, we just encourage repositioning. But about 6 months to that 6 to 8, 9 month age, repositioning is not thought to be as effective, and we think that helmeting at this point would be good. We still do encourage repositioning as part of the therapy, but if it's moderate, if it seems to bother the parents, then we do prescribe a helmet, and this is worn for 4 to 6 months. There are social considerations with helmets. They do cost money, they do require follow-up, and they do require changes in contouring, so you have to counsel the family that there is some maintenance or management that they have to do in terms of the helmeting. And greater than a year, to be honest, there's not really much you can do. And fortunately, most flattening's in the back, and the hair will cover it, and you just kind of encourage parents. Obviously, positional plagiocephaly has no underlying effect on neurocognitive or neurodevelopment whatsoever, so it's really a cosmetic thing. But if a kid's over a year, at that point, there's not a lot we can do. This is contrasted with synostosis, obviously much, much more rare and treated at major children's hospitals with a multidisciplinary team. Most synostosis surgeries are done with a plastic surgeon and a neurosurgeon together. It's premature fusion of one or more of the cranial sutures. When it involves one suture, it's almost always just an issue of cosmesis. Although it's debated in our literature that it may affect brain growth and development if it's multiple sutures, then what we don't understand is why people get this, and there may just be whatever's predisposing a child to get this may also have some implication for development that's still unclear. But in general, when I'm in clinic and a patient comes in with one suture, one issue on the forehead, or just the sagittal suture, I tell parents that I would not be concerned for the child's development. Not every neurosurgeon would fully agree with that, but I think in general the kid's going to develop just fine, and I don't want to scare parents. What about fontanelles? We see fontanelles closing at a wide range of time, and is it a problem or is it pathologic? I really, unless the kid has synostosis, and that's why there's often their sutures, their fontanelle stays patent, I generally don't see kids, or I'm not really concerned with early or late closures of fontanelles. There's a wide range, just like all the developmental milestones. When should a kid walk? When should a kid talk? I mean, there's wide variation in the ages and when that should happen and what's pathologic. And so I think it's very similar for fontanelles. If a pediatrician ever feels that it's closing too early or it's closing too late, I think it's a very good referral to a neurosurgery clinic. And I certainly have seen kids, and often I don't know, and I get an MRI and work it up, but most of the time it's just a wide range of normal. The posterior fontanelle is small and can often be closed at birth, but it's usually gone by a couple months of age. It's the anterior one that's really happening close to or around age of 1, but even up to 1.5 or even closer to 2. What about the sutures? So the metopic, which is you have a single metopic, which is the ridge on your forehead, that closes very early. That's not often associated with synostosis. It can be, but really that suture is just meant, or we're just made to have it close very early in first couple months of life. The others, we have one sagittal down the midline, the coronal and lambdoidals, and they can close anywhere between 22 and 39 months. To be accurate, we don't fully ossify our skull until we're into our 30s. So this is a very wide range, but unless the head shape starts to be abnormally shaped or there's ridging, closure of sutures can be pretty varied. So how do we diagnose synostosis? It's really based on physical exam postnatally. We look at the head shape. So, every synostosis comes with its own distinct head shape. The most common being sagittal synostosis. Those kids get really long heads or scaphocephalic heads. We call them like boat-shaped heads or football heads. It's really something you can look at and pick up on exam. You also can palpate where the suture is, and if you feel ridging, that's indicative of possible synostosis. Imaging, skull x-rays really do not give more info than my exam or our exams do, and they're often misinterpreted by radiologists, so I tend to never get skull x-rays. If we're going to image, the best image is a 3D reconstructed CT scan, which is a special type of CAT scan that has to have a special machine to do the recons, but most of the time we don't need any imaging to make this diagnosis. So again, just to say a CT and MRI are nothing, the considerations with a CT is sometimes we do need it just to plan our surgery and decide what cuts we're going to make in the bone and whatnot, but it is a dose of radiation and it can require sedation. And MRI is really, if you're concerned about underlying brain abnormalities or a syndromic type of child, you would get it just to look at the bony abnormality. It requires sedation, and can be tough to schedule at pretty much any children's hospital I've been at. So really, I like to just say to save imaging for the neurosurgeon's office. So just based on exam, that's a good enough for me for a pediatrician to send the kid over and for us to take a look, and then we can make the call from where to go with the imaging. And this is again just going over the different types we have and how each of them comes with their own characteristic, beyond being normal cephalic in the middle, but each has their own name and classification for how the head will be abnormally shaped. This is how we do the incision for an open repair. So you see that curvilinear, or on the left there's a zigzag, and the middle it's a curvilinear. That's the incision we make for most synostosis repairs. If we're going to do it endoscopically, which is only available to a particular patient population, it we do it with those small incisions that are made near the forehead and near the back of the head. So on that one child's head, they've drawn out both the incision types and the kid on the right. Just to give you an idea of, what the child in the bottom left corner, he had scaphocephaly, sagittal synostosis, and then he had repair, which you can see how his scar is pretty well covered under his hair. He's got shorter hair on the side there, but looks pretty good. Usually, honestly, I even think the scar is less obvious than that. So, okay, so moving on from synostosis, another very common thing is big head, so macrocephaly. So this is a head circumference, or an OFC, greater than 2 standard deviations above the mean. Less than 2 standard deviations above the mean, but disproportionate when ethnicity and stature are considered. So some kids are just bigger, and to be honest, there are different ethnic populations that have larger heads or smaller heads. I'm new to the area, but my nurse practitioner, Barbara Bell, has been here forever, and she's convinced that children of Navajo descent, ethnically, this population just has larger shaped heads, and often I get a kid come in with concern for a large head, but mom and dad have very big heads, and so it generally doesn't mean anything. So most commonly, macrocephaly is benign familial macrocephaly, like we just discussed, but all these reasons I just clicked on are reasons why we do have to look into it, because it could be one of these things. That is, the brain itself can be big. We can have water on the brain or hydrocephalus, and that's always our biggest concern. Is the bone thick? So does the child have hyperostosis? Achondroplastic children and people with other syndromes such as neurofibromatosis and Alexander's also come with macrocephaly that is associated on the spectrum of their syndrome. So just to recap on abnormal head shapes, the key points, most common thing that we see in all our clinics is positional plagiocephaly, and we discussed the management and sort of how to help reshape heads. Age of referral, the earlier the better. So whatever the pediatrician is comfortable with. But if they have any concern and they just want to have the kid checked out, we have head shape clinics as pretty much every children's hospital does, a synostosis or head shape clinic. And the earlier the kid gets in, the better, because if it is synostosis, the younger they are, the more surgical options they have. We can't do endoscopic surgery on a kid who's older than 5 to 6 months, because the skull base is starting to form and the head shape is starting to form. There's a lot of considerations, but if parents really want endoscopic treatment, we have to see them earlier. So perfectly fine for a pediatrician to just keep observing and counseling and treating the child, but there's nothing wrong with sending early as well. Imaging, again, I don't think X-ray is very helpful, and I think that we should decide what to order in craniofacial clinic, and often we just don't image the kid at all. And then for surgical options, age, and then some of our surgical repairs require helmets after, and some of them don't, and so that just comes into play when we're talking to parents. It's not often just the surgery and the recovery, but there could be 6 to 8 months of helmeting after. Let's now talk about hydrocephalus. So hydrocephalus is an increase in the fluid-containing spaces of the brain that is at increased pressure. It's a mismatch between CSF production and absorption or flow. It is to be contrasted with cerebral atrophy, ex vacuo changes, or children who have benign CSF spaces that are not hydrocephalus. So again, having large CSF spaces, if they're not pathologic, if they're not causing a problem, the head's not getting big, if the fontanelle's not bulging, if the child isn't symptomatic or isn't developmentally delayed from it, is not hydrocephalus. It's basically just ventriculomegaly or extra fluid. It's hard to estimate how many children have hydrocephalus, and it's often secondary to another problem, so a brain tumor that gives it, or intraventricular hemorrhage, or a trauma that gives the child hydrocephalus. But in newborns, just congenital hydrocephalus, it's 1.5 per 1,000 births, and fortunately, that rate is decreasing in the United States. There are 125,000 people currently in the U.S. walking around with shunts, and about over 30,000 shunts are placed or revised annually in this country. So here is a picture that contrasts ventriculomegaly on the left and hydrocephalus on the right. And so if you look at the inner spaces, the ventricles, they actually, just looking at just those structures, they look pretty similar, right? Both very big, rounded, bigger than they should be. But then if you look at the surrounding brain, that's how we can determine if it's hydrocephalus or if it's just the way in which the brain has been made. So the child on the left has you see black areas of CSF around the gyri of the brain and large spaces. So this kid has atrophy for some reason, has brain loss for some reason, for a number of possible insults. But this is not something we would shunt. Yes, they have very large ventricles, but it would actually be a very bad thing to subject this patient or this child to a shunt. You could actually overdrain them and give them bigger problems. But if you look at the picture on the right, you look at the brain and it looks very full. It looks, you don't see the sulcal pattern. And almost, if you could imagine, you could feel like the brain is a sponge and it's being pushed up against the bone. There's no black areas around the brain. There's no areas of CSF, and that's a brain that's under pressure. And so that is hydrocephalus, and the kid on the kiddo on the right would need treatment pretty quickly. I bet that kid's probably pretty sick. So again, it's not just the fluid spaces or the amount of CSF, but it's what is it doing to the brain. So the etiology, it could be congenital, or it could be acquired, like we just talked about. About a quarter of kids with shunts have it because of intraventricular hemorrhage. Most children with intraventricular hemorrhage do not go on to develop hydrocephalus. It's really the extreme intraventricular hemorrhage population who have the problem with hydro and get shunts. Most children with myelomeningocele have shunts. But if you look at the overall percentage of kids walking around with shunts, it's about 1/5 of our population. And so spina bifida is very commonly associated with hydrocephalus. And then all the other reasons we know about. So tumors causing obstruction, aqueductal stenosis, which is a congenital problem, meningitis. So post-meningitis, there's always the risk of developing delayed hydrocephalus from that. Head injury, and then in up to 10% of patients, we end up not knowing why they developed hydrocephalus. So the signs and symptoms. So young children come with their own set, which is very distinct from older children. And the age of distinction I'm making is when your fontanelle is closed. So when your skull can still compensate and grow, and we still have that physical exam gauge for us, the fontanelle, that brain will react differently. But once your calvarium is a closed structure, hydrocephalus is going to treat you very differently. So in young children, failure to thrive, to reach their milestones, they'll be drowsy, irritable, poor feeding. We always say, we go to the NICU, we talk about A's and B's, apneas and bradycardia. And then, of course, bulging, tense fontanelles. A head circumference that's continuing to grow, that's crossing percentiles. The scalp veins become very distended and full. The sutures are splayed, and then this upgaze palsy. Of note, seizures rarely have anything to do with hydrocephalus. So a very common ER consult is a child with hydrocephalus, also with a seizure disorder. They come in with seizures. Often they've outgrown their dose of antiepileptic, or mom and dad missed antiepileptic, and the very first person they call is a neurosurgeon and say, is it the shunt? And almost never is an exacerbation in a seizure disorder related to a shunt. Or hydrocephalus. It's just an interesting thing. They're connected, but they're not really causal. Older children with hydrocephalus or decompensated, maybe intermittent, or have been kind of just sort of making it by with shunt failure, will have learning problems in school and focus. They tend to get morning headaches. Intracranial pressure is always increased in the morning because you've been sleeping and laying flat for hours, and so it's had time to build up overnight. And gait changes. Acutely, so when a child is very sick, it's the things we know: severe headaches, vomiting, papilledema. They'll have blurred vision, or they'll have raised optic discs if we look in the back of the eye, and double vision, or from a sixth nerve palsy from impending brain herniation. So in little babies, obviously need an open fontanelle. The quickest, cheapest, and most convenient way is to study them with ultrasound, and this is how we follow little kids, kids under 6 months or till their fontanelle is closed. A CT is quick. You can try it without sedation, and I honestly think it's okay to CT a kid now and then, but we can't do it too often, and we know it comes with the cost of radiation. And so what we like to do are very quick MRIs. UNM is actually very good at getting these done quickly, faster than I've seen at other hospitals, but it's we can do it what's called a haste MRI, which are sequences that happen in about a minute and a half. You can get a full MRI, so it's as quick as a CT, and it looks at the ventricular system. This is the best imaging, obviously, but if you need a full MRI, you might have to put the kid under even general anesthetic, and so that becomes an issue. So management, again, just to reiterate, not all patients with enlarged ventricles need a shunt. It's worth an evaluation with a neurosurgeon, but that's sort of the nuance. That's like my job, is to figure out which ones need shunts and which don't. Fortunately, with intraventricular hemorrhage, we can watch those kids. We can even do serial taps, and sometimes in the NICU, we can clear their hydrocephalus. Tumors or masses, sometimes just taking out the tumor itself will, half the time, resection will do it. Half the time, those kids, even if you take out the whole tumor, they're still going to need a shunt. Arrested hydrocephalus are older kids who maybe aren't doing great in school and maybe a little delayed in general, maybe didn't see a pediatrician as much as they should have as a younger child. And you image them and they have large ventricles, but they're sort of past the point where you would do anything about it. It's not currently causing problems. It may have affected their development at a younger age, but doing anything about it at the age of 6 or 7 or 8 isn't necessarily going to fix it. And then the two options for management are a shunt and an endoscopic procedure called an ETV, which is endoscopic third ventriculostomy. Now, this is a wonderful surgery. It's fast, it's easy. We go in with the camera, but it's only for a very particular subset of patients. If we could take every child who has a shunt and just do an ETV on them and get them shunt free, it would be the most amazing thing in my field. But it's not possible. So anytime we can consider an ETV, every neurosurgeon will give it a shot, but unfortunately 90% of the time your kid's they're gonna need a shunt and an ETV is not gonna work for them. Prognosis, so what do we say when you put a shunt in a baby or a younger child and the parents say, so what's my kid gonna be like? And honestly, it has a lot less to do with the presence of the shunt and more what the cause is. So infection, intraventricular hemorrhage, do they have a hypoxic ischemic injury, a tumor? I mean, the tumor itself may have more prognosis on the child than hydro. I mean, they may have a fatal or mortal tumor, unfortunately, the chemotherapy, the radiation. So you have to really take into consideration the cause and a lot less, well, my kid just has a shunt. But if we just look at congenital hydrocephalus, there was a study that looked at about 250 kids who just were born with hydrocephalus, no other problems. They just had, big ventricles causing pressure, no known infection, no traumas, just, your run-of-the-mill congenital hydro. And they followed this group of kids for 20 years. 15% had died, mostly from shunt-related complications. The average had close to 3 shunt surgeries. So, I always tell parents, your kid may have a shunt surgery every year, or you may never have a shunt revision until you're 20 years old. I have the kids who've had 30 surgeries in their life, and I have the kids who've had none. So the average is 3. 2/3 of kids born with hydrocephalus and shunted were considered normal or quite, well functioning in school, which is a good thing to tell parents. They're not necessarily going to need special education or they might just be a kid in school, normal classes. They do much better than children with hydrocephalus secondary to infection or hemorrhage. That's because if you have intraventricular hemorrhage, you were born prematurely almost all the time. Mature, full-term babies almost never have intraventricular hemorrhage. And there's so many problems associated with prematurity other than the presence of the shunt. And then infection, you can imagine meningitis and all the scarring and all the problems it causes to the brain itself. It really has more implications on the prognosis than the shunt itself. So shunts, like I said, are the first line treatment really considered before we can do this endoscopic treatment. They have 3 parts. They have the part that goes into the ventricle, the part that it comes out of the head through a little hole in the skull. It has a valve which sits on the skull itself, which is the part you can often feel or palpate. And then it has the distal tubing that goes from the valve and goes most often into the belly, sometimes to the heart or next to the lungs in the pleural cavity. And of course, unfortunately, shunts come with complications, which include breakage and blockage and infection. Most shunt infections are within 6 months of placement. So if you have a kid who's 4, 5, 6 years out from a shunt and they have fevers and they're sick, it's very unlikely it's going to be a problem with their shunt. It's probably something else. But if I have a kid come in who's recently had a shunt placed with it even up to the last year, and they're in the ER, and that ER pediatrician calls us, we're going to tap that shunt to figure out if it's infected because it's a high risk. So the way I follow, there are as many ways to follow shunt kids as there are neurosurgeons. I see kids initially like 2 weeks to check on their wound after a shunt, like you see any surgery, then 3 months after the shunt, and then 12 months after the shunt, and then yearly. I think just the takeaway message is that kids with shunts should be seen, and neurosurgeons recommend that we see the kids yearly. Really, this is to counsel parents on shunt malfunction, and because there are a lot of kids with shunts who don't get very, very sick. They don't necessarily go into shunt failure and then go comatose. That's an obvious shunt failure. But there are a lot of people who maybe aren't reaching with their potential. particularly kids with spina bifida that could have low-grade shunt malfunctions and could be not feeling as well or doing as well as they could be unless their shunt was fixed. And I think it's important that we catch that large number of kids. And just as a side, parents always ask, can this shunt come out? Is it permanent? What does it mean? And they're almost always permanent lifelong problems or instrumentation. So shunt considerations, failure comes with a range of symptoms. Like I said, it doesn't mean the kid, wakes up one morning and then goes into a coma an hour later and they're dying. Shunt failure can last for weeks and months. It can be low grade like headaches. Their visual acuity isn't as good as it used to be. They may just be taking more naps or be sleepier than normal. In myelomeningocele kids, any symptom is possible. So if your kid even says their toe hurts and they are a myelo child, it could be from their shunt. And the number one thing that we do in every kid with a myelomeningocele, before we image their spine, before we worry about their Chiari or anything else, is we make sure it's their shunt, that their shunt's working for them. The acute, obviously, are the symptoms we all know, the severe headaches, the throwing up, the diplopia, and comatose. Another important thing is imaging does not always show shunt failure. In fact, I think more times than not, a CAT scan or an MRI doesn't look any different. So if you have a shunt placed when you're a baby, your brain, however it continues to form and develop while it's being myelinated over the next couple of years, the compliance of people with those brains is very different from the compliance of people who never had shunts placed. So their ventricles don't necessarily change. When they build up fluid, it just gets more dense within that space and it puts more pressure on the brain, but it doesn't mean that the ventricles actually blow up. So I think there are a lot of shunt failures that are missed because someone will image them and say, oh, the radiologist says it looks relatively the same. But for me, that means nothing. So I really always tell my residents and train my residents that when you are concerned for a shunt failure, you have to interrogate the shunt by tapping it or looking into it. You can't just eyeball a CAT scan and say that a kid's not in shunt failure. We unfortunately cannot predict who or when will fail. We do know that younger kids, so infants, and the use of an endoscope to place the shunt are actually associated with a higher risk of failure, but those are the only two factors we've ever identified. Otherwise, I cannot look at a kid and have any indication if he's going to live 20 years with that shunt or if he's going to be in my office in 2 weeks with a shunt failure. With infection, like I said, most infections occur within 6 months. Rate of infection ranges. Some centers are down to 1 in every 100 shunts getting infected. Some places are as high as 7. If you really have a rate over 7% of your shunts getting infected, you should look into your OR and what you're doing because you're probably doing something wrong. But it is known that there will be a set of shunt infections. A febrile child with a shunt, I think it's important to rule out other causes, the usual stuff we do for babies and children with shunts, but very quickly I would move to tapping the shunt. So I don't think it's very excusable for adult neurosurgeons or other neurosurgeons to not offer or be amenable to tapping the shunt for a pediatrician who's asking us to do that. So I'm always like, yes, look into the shunt, and often it is the shunt. So if you guys ever call and you want CSF started before you want to put on antibiotics, I think it's our duty to go as neurosurgeons right away to interrogate that shunt while the pediatricians are in the midst of their, sending the urine and sending everything else. So it's not good to LP kids with shunts. So you can actually put a shunt into failure by doing a lumbar puncture because you change the pressure differential, and the CSF will actually want to go out the puncture hole as opposed to using the shunt, and then it shuts down the shunt. So again, when a kid comes in with a shunt with a fever in the ER, I think within 5 minutes, an appropriate call is to the neurosurgeon to say, can you please come take a look at your shunt? It's not something that we, rule out some disease from sub-Saharan Africa on some cytology test and then tap the shunt 10 days later. It's very important in the initial workup. So just the key points on hydrocephalus, and then we're pretty much done. All causes necessitate different treatments, but unfortunately, that's almost always a shunt. The imaging depends on the stage of workup. Treatment options are unfortunately shunts. An endoscopy is a great option, but it's very limited in its application. And again, it's important that shunt kids are seeing their local neurosurgeon at least yearly. Spina bifida. So spina bifida is many diseases, but the most common one is myelomeningocele. Most of these kids have shunts, but not all of them. But when there is a problem, always rule out the shunt first. So if your Milo kid is in clinic and they're complaining of anything, the first option is really to have their shunt interrogated. Their spinal cord will always be tethered by definition. Every child has a Chiari malformation by definition from having a myelomeningocele. So, we can say it's a bunch of other things, but almost all the time it's a problem with their shunt. And these kids really, and I think everybody knows this, should be followed in multidisciplinary spina bifida clinics, and every major city and children's hospital has one of these, with urology, orthopedics, neurosurgery, physical medicine, social work. What about occult spinal dysraphism? So the most common occult one is a tethered cord, and this most commonly is from fatty infiltration of the phylum terminale. A lot of babies get postnatal ultrasounds, and this is almost never helpful whatsoever. The best and only diagnostic imaging is an MRI, and if it shows fat in the phylum or a low-lying conus, but that's an indication that the kid could have a tethered cord. So until a kid is about 6 months of age, the phylum has not ascended to its final position, so the spinal cord and the spinal bones grow at a different rate. And so every baby has a spinal cord that's basically at the bottom of their spine when they're born. So if you imaged every newborn, every kid would look like they had a tethered cord. But what happens is the spine bones grow faster than the spinal column, than the spinal cord. And so it looks like the cord itself is moving from L5 to L4 to L3 to L2, and then it stops around L2. But it's really because the bone around it's just growing faster and bigger. So it means nothing to me to see a young baby with a diagnosis of tethered cord. So when we do work these kids up, we like to do it about 4 to 6 months of age. At that point, I will order imaging, and I almost always get an MRI. Not all phylums need a treatment. So this is very controversial. Some people do the surgery prophylactically, and there's actually a study that if you cut a child's fatty phylum, they will grow taller, because they followed a cohort of children who didn't have it done, and then other kids who did, and the group who did were a little bit taller. But it's very, controversial in my field whether or not you should operate on these if they're asymptomatic, or if you should wait till the child develops a problem. But I think the take-home message here is this is something we don't really look into until the kid's a little bit older, and then at that point the best thing to do is to image them. So that's it for my slides, and to go over the questions, the 4 questions I put out at the beginning. So the most common head shape abnormality encountered in our clinics are positional plagiocephaly, or flattening. It's an abnormality, but fortunately it's not really a pathology. But it is important that we catch the kids with synostosis. Most children with spina bifida have shunts for the treatment of hydrocephalus. This is true. It's up to 80% at least. Some kids are very fortunate and get away without needing it, but at this time we're treating most of these kids with shunts when they're infants. Most pediatric neurosurgeons follow children with shunts. This is true, and most of us do it at least yearly. Once they're out of that acute surgical phase, we look at them. We like to see them back yearly just to see how they're doing. And tethered cord in infants is best diagnosed on an MRI around 4 to 6 months of age. So doing CAT scans or doing ultrasounds when they're first born, a lot of that is not helpful at all. And the best time is to wait till the kid's a little bit older and to get the kid an MRI. And I'll show you what you need. So, all right, I think that's it. Thank you very much for everyone listening. And now if there are any questions, I'd be happy to take them.
If you don't have audio available, please feel free to use the chat box. Be monitoring that as well.
So I think I have a question. Yeah. While we're waiting. So for the spinal dysraphism, is this for any kiddo with a PIT?
So ones that are in the gluteal cleft or just above it tend to be nothing. It's when they're a little bit higher, so they're actually like low lumbar. But yeah, I think any kid certainly with a PIT, if they have a little tag or they have hair, that's iffy if it's going to be a problem. But I probably would still have that kid looked at. Yeah.
And would you wait on those kids, or get those done earlier, and then the kids with it a little bit higher wait till they're 4 to 6 months?
I would pretty much wait on all of them until they're a little bit older, unless you notice something very obvious, like one of the legs doesn't kick, or, you know, something that was like kind of striking to you. I would wait, because I'm going to see the kid, probably not notice anything, and then tell them to come back in 4 to 6 months. So I probably would wait. Yeah. Unless there's an obvious already manifesting neurologic problem, which most little babies don't manifest their tether cords that early. So.
And what is the average age kids need revisions, shunts?
There is no average age. Young babies are at the highest risk of having shunt failures. So there's a high rate of revision in young kids, meaning the first year of life. And then they, for whatever reason, tend to have a shunt revision or two and then be good for a while. But there's no age. It's not like every 10-year-old or whatever needs a revision. Sometimes the kids outgrow the length of their distal tubing, and so a lot of neurosurgeons around the age of 10 to 13 will get x-rays to look at their tubing. I don't tend to do that. I wait till the kid is has symptoms of a failure to do anything about it, but there's no average age whatsoever.
And do we have any other questions from anyone out there?
You can ask anything you want. No.
We have a wealth of knowledge in this room.
Yeah.
So what do you do if in rural area with position?
Possible shunt infection and 2-hour flight. Can you? I would have the kid. Oh, I see. So the problem with giving antibiotics is, well, often the numbers, so the glucose, protein, and the cell counts will still be useful after a shunt tap if a kid already got antibiotics. What is less useful will be the culture. So often the culture will not grow an organism. It won't, by the time when the kid gets to us, it's managed with a neurosurgeon and an infectious disease specialist. We still will treat the kid for a certain duration on antibiotics. So to be honest, we don't have to know what the infection was, what the bug was. But if the kid looks great, I would fly them and not give anything. But if they have a fever, you have any concern whatsoever, then I think it's the right thing to do is to start the antibiotics pre-transfer, because we can still glean enough information from our shunt taps to figure out what we need to do with the kid long term, or how to treat it and get through it.
Thanks, Jillian. Any other questions? Thank you, ma'am. That was excellent. That was very interesting. I found it very interesting as a computer person. So I think that is going to cover us for today. Did you have any other announcements or anything you wanted to say?
We are still working on a December talk, but we do have one in January. A pediatric cardiologist is going to speak, Dr. Ann Green, and I'm not sure her topic just yet, but we'll definitely advertise that. But Kevin, thank you so much for this and
Thank
for
you.
everybody here at Envision helping us. And thank you. That was very helpful. We appreciate it.
So stay tuned on our Envision envisionnm.unm.edu. It's changed a little bit. You can still go to envisionnm.org. It will redirect you, but we have moved over to the UNM server. So you might want to change your bookmarks if you have any of those. So go to our calendar. It still looks the same. It just has a different URL. And check back there and watch for Michelle's emails for future PEDx sessions. So thank you very much, and we'll go ahead and sign off.
Thank you, everyone, for listening.